So thanks, Vanati, for making me a part of this IC. So basically, when you look at dry eye or Sjogren syndrome, the common questions that are asked by common general ophthalmologists is, do you need to evaluate the dry eye in all patients? And what is the clinical tool that you would use to evaluate a dry eye? And do you need to actually get all these latest gadgets to evaluate dry eye? I would probably think a fluorescein stain is to a large extent sufficient to give you a reasonable amount of idea about the dry eye status. It not only gives you an idea about the corneal staining, but if you look at the tear meniscus height, you look at the pattern of breakup of tears, and you look at the flow of the tear film along as the lid goes up, it gives you a reasonable idea as to a type of dry eye and what is the severity of dry eye. So if you have gadgets, newer diagnostic tools, go ahead, use it. But if you don't have that, it doesn't mean that you cannot evaluate or treat a dry eye patient appropriately. The second question would be the need for a rheumatological consultation. Obviously, anybody with a Schirmer's less than 5 who does give history of joint pains, who does give history of dry mouth, should have an evaluation by a rheumatologist to rule out a coexistent rheumatological condition, because these patients, whenever they require cataract surgery or they require any other surgical procedure, you might have issues with their wound healing or post-operative inflammation. And in patients with dry eye, when you're tackling them for cataract surgery, you have certain other issues. They have an altered microbial flora, which could increase the risk of endophthalmitis or keratitis. You can have concomitant ocular surface inflammation. You might have issues with IOL calculation because the corneal surface is not so regular. You might have decide on the type of cataract surgery based on the visibility that the cornea offers. And again, when you're choosing the type of lenses, you will probably have to go for a monofocal lens, because multifocal lens in a dry eye patient is probably not advocated. If you have coexisting other issues like achilliasis or an issue with SLKC, you might want to address that whether with the cataract surgery or prior to the cataract surgery. Some patients do complain of dry eye features after cataract surgery, which could probably be a missed pre-existing dry eye, achilliasis, meibomian gland dysfunction, or the toxicity due to preservatives in the tears, or an incision site damage to the nerve as such. So preoperatively, a good examination, a thorough examination of the lids to rule out any causes for blepharitis, meibomitis needs to be done. You need to refer these patients to a rheumatologist for them to do what they call as the DAS28 ESR or the DAS28 CRP questionnaire and tell you that the disease is in remission or is in a low disease activity state. You don't want to operate on them when the disease activity is on a high scale. So if you have severe dry eye, obviously when your corneal surface is lacking luster, you might want to address that. In this case, we did a punctal occlusion with a cautery, and then once the surface gets stabilized or better, then you can go ahead and plan for a cataract surgery. Again, whether you want to go for a scleral incision or a corneal incision, the debate is still on. We've not generally moved on to a corneal incision. Suffice to say that your incision should be as small as possible, and the threshold for using sutures should be as limited as possible. I mean, you would want to use the sutures in case of any doubt. In the post-operative period, you would want to defer NSAIDs because there is a possibility of epithelial breakdown causing corneal melts. As such, use preservative-free medications as much as possible. Like I said earlier, if you have combined issues like achilliasis or severe dry eye, you might want to combine it with the cataract surgery. And if you have a PED, you have a thinning, you have a stromal edema, non-healing epithelial defect in a patient with Sjogren syndrome, you might want to send them back to the immunologist to hike up the systemic medication as such. Coming to the next topic would be Stevens-Johnson syndrome. What are you basically looking at is two things. How do you address the dryness, and in terms of lid margin keratinization, and the role of Pro's lens. As far as keratoprosthesis is concerned, it is basically when the surface is keratinized and you are not able to improve the vision with a Pro's lens, you are going to consider keratoprosthesis as an option. So coming to cautery, you have it as a very useful tool for severe dry eye. And the other option is to use scleral lenses, but then they are more expensive. A cautery is a very simple procedure, and even in a couple of days time post cautery, the surface inflammation significantly comes down. Yes, it can open up again, but if you have to redo the cautery, it's a very simple procedure. The next thing would be the lid margin keratinization. You can see the lid margin keratinization causing a blink-related microtrauma on the surface. The SPKs are directly coinciding with the area of the keratinization, and this needs to be addressed either by a Pro's lens or by a lid margin mucous membrane grafting. And this improves the patient's symptoms. It reduces the corneal damage, and especially if you have to plan any other intraocular procedure post-op, you need to address the lids before you go do an intraocular procedure. And just addressing the lids significantly reduces the ocular surface inflammation. You don't need any steroids in the early postoperative period. This is a patient who refused surgery initially and then came back after about a year with an increase in his haze and vascularization, then underwent the lid margin MMG, and then his vascularization also came down and his haze also came down. So just addressing the lid margin keratinization significantly improves the ocular surface health. Again, what is the age? There is no specific age. You only need to be sure that the oral mucosa has healed before you go ahead with the procedure if you feel that the lid margin is causing the abrasion on the ocular surface. If it recurs, what do? The answer is very simple. You can redo it. You have an ample source of lip tissue available, so it's not a problem as such. And sometimes you might need to do multiple procedures. You might need to do a cautery, you might need to do an MMG, you might need to do a cataract surgery, and then give the patient a Prose lens. So you need to comprehensively look at multiple options to make sure that they have a reasonable visual outcome at the end. Coming to chemical injuries, the common questions is which classification to use, and how many times do you want to repeat an amniotic membrane, and how do you treat a grade 5 or a grade 6 Duas classification. Duas classification basically classifies it based on conjunctival involvement and corneal involvement, and it is important because it tells you whether the epithelium is there on the extent of epithelium which is there on the ocular surface. Now, if you look at a small corneal epithelial defect and much less of conjunctival defect, it might heal with a bandage contact lens and topical steroids. But if it is large and you have an you have a scleral line plaque or a corneal line plaque, obviously you need to do a surgical removal. When you look at a eye like this, which is a grade 6 Duas, where there is almost fornix to fornix lack of conjunctival epithelium, there is lack of corneal epithelium, this would need multiple surgeries. You can do an amniotic, but when we have done amniotic alone in these eyes with severe burns, the number of times that we've had to repeat the amniotic has been huge because there is no source of epithelium to populate the ocular surface. So in these patients, more than grade 4 Duas, we have started doing what we call as the alloslet in an acute chemical injury, the idea being to epithelize the ocular surface as fast as possible so that the further complications with respect to a corneal scarring, melting, perforation can be avoided. Again, when you look at the previous photo and this photo, this with the scleral ischemia is much worse as compared to the previous photo. So even though both are grade 6 Duas, you probably require a lot more surgical intervention in this patient as compared to the previous patient. Again, when you have a melted cornea, it still comes under grade 6, but the prognosis obviously is worse as compared to the previous two images. And when you have such a severe Tenon's ischemia, then you would probably want to combine it with a tenonplasty and an amniotic. And this patient actually ultimately required a keratoprosthesis. And even though he got back 6/9 vision, but it's multiple surgeries and a lifelong follow-up that he has to undergo. Now, the next question is, when would you want to do a stem cell transplant? You would want to do a stem cell transplant only once the eye is significantly quiet, and minimum is around 6 months post the acute injury. Sometimes post amniotic in the acute patient phase, patients come back with decrease in vision, haze, and you can see the stippling on the surface. There's no urgency to rush for a repeat procedure or a stem cell at this point of time. Just give it time. The surface epithelium heals and it smoothens, like is seen in this patient. It is seen again in this patient, where over a period of time, by just observation and lubricants, the surface quietens. So you don't have to rush for doing a stem cell transplant in an acute chemical injury. Again, another patient where you can see the staining pattern of the epithelium at the 1 month post injury, and then at 2 months, and then at 6 months. So it definitely shows an improvement gradually as you give time for the epithelium to remodulate. Coming to OCP, how would you identify the disease? How would you monitor progression? When would you start a systemic immunosuppression? These are the commonest questions. Obviously, you would need to look at fornicial shortening, repeated episodes of inflammation, monitor the fornicial depth, take serial photographs to document it. If you have ruled out other causes of cicatrizing conjunctivitis and you're very much sure that this is OCP, you can confirm it by doing a conjunctival biopsy. But even if your biopsy is negative, doesn't stop you from starting the patient on systemic immunosuppression, because the treatment for OCP is systemic immunosuppression. So, and if you're doing a cataract procedure or anything, you would need to address the dryness, you would correct the lids, you would put the patient on systemic immunosuppression to control the disease. And then when you're doing a cataract surgery, it would be preferable to do a corneal approach as such. When you're talking about cataract surgery with pterygium, the questions are, should you do it together? Should you stage it? So basically, if you have a less than 2 mm pterygium, you can do it together. If it is more than 2 mm, you would want to do it as a staged procedure. But obviously, it involves a discussion with the patient as to what the patient expects at the end of the procedure. What is the ideal duration between a pterygium surgery and a cataract surgery? We do not have very great guidelines, but approximately about a month, allowing time for the keratometry to stabilize, would be reasonable. So if you have a small keratometric error, you could probably combine. If you have a high cylinder, it was preferable to do a staged procedure. If you have a post-pterygium astigmatism, which is reasonably regular, you might even consider doing a toric lens. Something like this, it's difficult, but you can still manage it with an amniotic, with a split conjunctival graft. But something like this requires multiple surgical procedures. It would be better to refer it to a person who's well trained in ocular surface reconstructive procedures. Last but not the least, somebody who presents with irritation, foreign body, mild redness, photophobia, take your time, just lift the upper lid and look at the upper tarsal, upper bulbar conjunctiva. This congestion is very typical of superior limbic keratoconjunctivitis. And if you treat that, the patient is going to be a lot more comfortable. Thank you.